Welcome to AETCM. Today we're going to discuss about an elderly female who was brought to here with a history of one episode of seizure.
Start.
So a 66-year-old female was brought to here with bystander giving a history of one episode of seizure that day early morning. So she was initially taken to another hospital, then the initial some management was given, then referred in an ambulance to our hospital for further management. So on arrival in ER, she appeared to be drowsy but arousable. So EVP scoring, she is responding to pain. She is not obeying to verbal commands or anything, but giving some strong stimulus, she is responding. So I went to the primary survey.
Yes, time from seizure. What's the time?
So basically, she arrived in the hospital around 9 o'clock in our ED, but this thing even happened around 3:30 a.m. Basically, she was asleep at that time, but the bystander noticed sudden onset of jerking movements and with frothing of mouth and uprolling of eyes lasting about 2 to 3 minutes. After that, she was a bit in a drowsy state. They took to another hospital, and there also she had one more episode of this similar episode. So there they give some medications which we later came to know was Midas and.
So currently the sensorium could be because of the drug itself.
Could be.
Okay.
So after giving some medications, they are referred for further management. So on arrival, she is drowsy but arousable, and so I went to the primary survey. Primary survey airway doesn't appear to have any obvious secretions or anything. There was no audible airway sounds. There was no gurgling or stridor noted. And breathing part, she had adequate chest excursions were noted, and she had a equal chest. Chest was clear with equal air entry, and respiratory rate was around 16 per minute, and SpO2 she was maintained at 97% in room air. Circulatory part, she had a heart rate of 68 per minute, and blood pressure record was 140/70. So disability part, her GCS is E3, V3 and M5. She was febrile, and also GRBS was checked. It was 108 GRBS. She's a non-diabetic patient. Anyway, as a primary adjunct, we took an ABG. It was not
Any other finding probably might have some relevance at that point, or might be pupils.
Pupils. Pupils are also checked. It was equally reactive.
Okay.
About 2 to 2.5 mm bilaterally equal and reactive.
Okay.
And sugars were checked was 108 milligram per deciliter. And we also took a VBG. It was not showing any acid-based derangement, but in our ED we have a multi-parameter this in VBG. So it was showing a sodium of 101 was the sodium.
Anything else you will be interested in ABG?
Lactate was elevated. Lactate was 2.2.
And pH?
pH was 7.44.
Okay. What's the relevance of lactate?
Lactate actually initially in the initial stages it can be elevated post
support. Yeah. Why?
Basically mainly because of the muscles sudden posturing of muscles and all that. There will be increase in anaerobic metabolism. So again can increase in.
How do you differentiate a lactate elevation because of seizures and probably because of any other causes?
It will come down by itself.
Rapid resolution is one thing. Okay. And it will be lactic acidosis, not pure hyperlactemia. Okay.
And then hypoxia also can cause seizures. So PO2, especially in seizure patient, apart from the acid-based metabolism, even the respiratory parameters have to be checked. PCO2 build up and also PO2 fall. Like hypoxia can cause seizures, but in this patient both were ruled out.
Fine.
So a primary survey is somewhat in the normal limit. So we into the secondary survey.
Yeah, sensorium is low, no? According to GCS is around 11.
GCS is low, but considering the history, two possibilities. One is actually maybe in a post-natal phase. Now she's continuing, and second will be secondary to that medications given. Most probably secondary to that. I think they're not given Midas, but
one thing we need to remember is that now we have a patient who already had 2 episodes of seizures. Okay, got some treatment. One is post-natal phase only. Another thing will be always keep in mind NCS, non-convulsive status. Okay. So that should also be part of your DD at that point. Okay.
So we went to the secondary survey. Secondary survey basically she is a non-case of CA cervix under follow-up in our hospital itself. Certain medications. So basically that day early morning, previous day night, as she was completely asymptomatic, she went to sleep. Morning around 3:30 a.m. the bystanders noticed suddenly she showing some jerking movements, and when they checked, she was having a uprolling of eyes and some mild frothing from her mouth, and also there was some like she was clenching her teeth and everything, and also there was involuntary passing of urine also. And this lasted for about 2 to 3 minutes. After that, she completely became in a drowsy state. So they immediately took her to the nearby hospital. After reaching her also, she was in a drowsy state, but I think she through one more similar episode. And the reference letter was showing they are given 4 milligram of lorazepam was given, followed by injection Levipil 1 milligram was given. And with this medication, they observed her for some time. They put her on IV fluids also, and about 1 hour later, they referred the patient to our hospital for further management. She doesn't have any non-drug allergies or anything. Her
Here, what will it qualify as status?
status.
So to call it as a status, patient should have multiple episodes of seizures with either no recovery between the seizures.
Just 2 is it needed? Okay,
Two-
at least 2
two-
episodes
two-
of
two
seizures.
episodes with no recovery, or each episode lasting for more than 15 minutes.
5 minutes.
Latest, 5 minutes. Previously
Okay, if
was
it is
15
persisting more than 5 minutes, or 2 episodes
with
without
no-
baseline to sensorium. Okay.
Okay. So her regular medication, she is taking Thyronum 50 milligram and also Atorvastatin 10 milligram. That's only regular medication she is taking. She's a non-case of CA cervix. Actually, currently follow up in our medical oncology department. She was recently started on this thing. Cisplatin chemotherapy was also started about 1 week back, within 1 week. And also she has a non-case of this thing. Recurrent hyponatremia in the past also, she had history also previously also, but her previous background is only hypothyroidism and dyslipidemia, for which she is taking regular medications. So before coming, the last meal was in the previous night only. In the last, if you're taking this last meal, and the only event was this GTCS. There was no history of any recent fever history, no history of complaints of headache, vomiting, diarrhea, no other issues were there. Basically, before this event, the previous night she was completely asymptomatic. She was like in a normal daily life. So I again went to a clinical examination, and now again reassessing the patient's sensorium is still drowsy only. Other systems are within normal limits except for the CNS part. She is still having a GCS of about E3, V3 and M5. But we couldn't assess any deficits at this point. So in view of that, VBG in the sodium in the VBG, we sent for a routine.
No focal neurological deficit.
No.
Reflexes fine.
Reflexes are fine. So we sent for routine blood demonstrations also. In that, the lab report came to be sodium showing 112.
Okay.
There was the sodium shown in this one. And other reports were within normal limits. This thing counts, everything was in normal limits only. Only thing was sodium was 112. And in ED, actually, after this thing about 2-3 hours, she again threw up one more a seizure-like episode. But this time it was more like in a focal-like episode. Initially, it started on the right hand, then it extended to the right limb and all that. So initially, we again give 2 milligram midas was given. But considering her hyponatremia, this thing, and with the symptom of seizure, we gave this thing, bolus of 100 milliequivalents of sodium at this point. We start after 15-20 minutes, we put a bolus, and then we started on an infusion. And before that, we also send the samples for serum, the sodium, hyponatremia workup and everything, and then started on hyponatremia correction also.
Okay, here, do we have any triggering factor for hyponatremia?
Thing is actually, she's recently started on cisplatin. There has been multiple case reports showing cisplatin with a single dose can introduce severe hyponatremia, even secondary.
What's the mechanism?
Mechanism mainly renal wasting syndrome. Basically, it is renal wasting syndrome mainly. Okay. Sometimes secondary to SIDH also. Okay. The main idea is renal wasting.
Any other drugs you know of which can cause hyponatremia?
Usually diuretics if they are taking anything.
The ones that are notorious to cause will be SSRIs, duloxetine, fluoxetine, all the SSRIs, and to an extent atypical antipsychotics. Along with this, thiazides and diuretics. Thiazides way more than loop diuretics. Then apart from that, carbamazepine, oxcarbamazepine. Then
so that is another interesting, because an antiepileptic itself causing hyponatremia leading to seizures. Okay.
So,
something which we nowadays see very much commonly in clinical practice but not much reports is PEG leg.
PEG leg anemia secondary causing seizure.
People are put for colonoscopy, given PEG leg, didn't pass rules, they will give one more PEG leg. Patient will end up with hyponatremia, severe hyponatremic features. Okay.
So in this patient, since it's an elderly patient, we have a lot of causes for seizures. So just hyponatremia shouldn't be the only diagnosis that has to be narrowed down. One, since she has a cancer history, brain mets can cause seizures, increased intracranial tension.
Of course, we'll come into those things.
So basically in ED, initially we stabilized the patient. Her IBC were within normal limits in the initial phase, but during ED, she throw up one episode of seizure. So we give initially this thing, midazolam was given, 2 milligram was given, and followed by considering her history of hyponatremia and all that, we gave an initial bolus of this thing, 3% saline, and after that we started on infusion. Before that, sending all the relevant investigations. So basically, considering her history of like CA ovary and all that, there
At
could
this point, we'll stop. And how will you work up hyponatremia? Sabha?
Sir, hyponatremia workup will be sending serum osmolarity, sodium osmolarity, and urine sodium. That's just to find out any, if at all we don't get any obvious cause of hyponatremia, this is the workup. So if at all patient has hyponatremic, in osmolarity, hypotonic hyponatremia, then it becomes true hyponatremia, because pseudo hyponatremia is the first thing that we have to rule out. Pseudo hyponatremia, one of the major causes will be hyperglycemia. So once we see if the patient has hyperglycemia, we do a sodium correction for glucose, and then we see whether the patient, despite correction, still has hyponatremia.
It's a numeric correction. Like, what's the
like
correction
a
factor?
formula. So basically, if anything above 200, every 100 we have to multiply 1.6, and we have to see the correction. Basically, this thing, for every 100 there will be a 1.6 correction should be added. Like if it is 300,
That is until?
until 400. If anything above 400, we have to give a correction of 2.4. So if it is like 300, then into 2 into 1.6, like about 2.3, like that. We'll
So that
add
needs
to
to
the
be added
sodium.
to the
Add to the sodium.
lab sodium. Okay.
So basically, it's showing a pseudo hyponatremia.
Then there will be osmolarity workup. In osmolarity, if it is low osmolarity hyponatremia, then it is true hyponatremia. If at all osmolarity is high, then it can be secondary to hypoproteinemia. The lipid levels have to be checked. So then if it is hypotonic, so that would be the osmolarity workup. Hypotonic hypovolemia can be caused again with loss of third space loss, like dilutional hyponatremia. Then after that, it can be secondary to thiazides or diuretic, obvious drug-induced hyponatremia. Then comes the role of urine sodium. If urine sodium, again, we take a cutoff as 20. If at all it is less than 20, then it is again dilutional or because of hypovolemic hyponatremia. If it is 20 to 25, then it is 25 to 40 would be the gray area, wherein patient has isotonic hyponatremia. Then if it is more than 40, it is renal loss. Either because of renal failure, but renal failure generally urine sodium won't go above 60. If it goes above 60, then we'll have to think of SIADH, the cerebral salt wasting, head injury. All of these can cause increased urine sodium. So SIADH in this is very natural to see. One, because of the cancer history, it becomes a paraneoplastic syndrome. So SIADH picture, you'll have low sodium, high urine sodium with high urine osmolarity. So in that, the treatment varies from the regular. For the dilutional, we don't really do anything. If it's an offending drug, we stop the offending drug. If it is secondary to kidney failure, then we treat the underlying cause. If it is SIADH, treatment varies. Like fluid restriction and Vaptans come into the picture.
Okay. So here, what's our major concern? Like, why is the seizure happening?
Basically, this patient actually we have to think
Because of hyponatremia. Because of hyponatremia, why is the seizure happening?
Basically, there will be fluid shift. The patient will have cerebral edema, which irritates, and following which patient will have seizures. So in this case, it becomes an emergency. Generally, in about 24 hours span, we'll have to correct 10 to 12 milliequivalents per liter.
That is for?
This, it will become
That is for?
severe.
That is for? This correction of 10 in 24 hours is for?
Chronic hyponatremia.
Acute.
like symptomatic hyponatremia.
Only for acute. If it is chronic, you should not be correcting that fast. Okay. For acute, it is 8 to 10, and for chronic, it is more of like 6 to 8. Just to use your
But if the
target.
patient has seizures, then we do boluses.
Yeah, and there again, the correction factor is approximately 0.5 to 1 milliequivalent per hour correction of sodium. Not the correction factor, but sodium, your aim is to correct. So that's approximately in 6 hours, we are aiming a correction of 6 milliequivalents of sodium. Okay. So the key factors are going to be an acute hyponatremia. By classification, what is acute hyponatremia? What's the time frame? It's 48 hours.
48 hours. Okay.
48 hours symptom onset is acute hyponatremia. Anything beyond 48 is chronic. So the rapidity in which the sodium has fallen is what is going to cause seizures at all. Okay. A chronic hyponatremic patient might come with a sodium value of 120 without seizures. But an acute hyponatremia of 124 might present with seizures.
Okay. So basically, hypernatremia we can classify into three, like mild.
And another catch for workup will be if already the patient is on diuretics and all, your urine sodium is going to be high. In those kind of patients, your sodium, if you go by the flow chart, you may not reach the correct thing. Okay. Continue.
So we can classify hypernatremia like mild, moderate, and severe. So mild will be about like between 130 to 135 like that. Between 120 and 130 will be moderate, and anything below 120 will be severe. So whether in any class the patient is symptomatic, we usually start with correction considering it is an acute event. Otherwise, depending on the patient history and all, we think about our corrections. So usually less than 120 ideally requires correction. About 130 we usually give oral correction, or like we add something in the diet to adjust that value. So acute hyponatremia with even the mild symptoms, they require correction. But especially if they're coming with features like coma, seizures, or anything like that, like very severe events, we have to give like a bolus. So the bolus protocol is basically we can give 100 milliequivalent, 100 to 150 ml of 3% saline as a bolus infusion over 15 to 20 minutes. And after this infusion, we have to repeat the sodium again. So our actually initial target is to correct at least 4 to 6 milliequivalents. This is our initial target. So as to like improve the or to stop the current acute phase. After that, remaining correction we will plan over a period of 24 hours to adjust. Our target will be around 8 to 10 over a period of 24 hours. But the initial target until we attain about 4 to 6, we give bolus. Maximum 3 boluses can be given of 100 milliequivalents. But suppose the patient is having an acute hyponatremia, but without not that much significant like symptoms, we can start a correction of over 24 period. Correction can be started. So in that, our plan will be to increase about 8 to 10 milliequivalents over a period of 24 hours. So we initially calculate the deficit, or like for each patient we make a plan of how much to correct. Then we multiply that with like a body quotient. There is a water body quotient. For male it is 0.6 and female it is 0.5. And along with that we multiply the body weight. So that is the required milliequivalents that we require for a period of 24 hours. And every bottle of 3% saline, that 100 ml bottle will be containing 51.3 milliequivalents. So with the calculation, we calculate how many number of bottles this person requires over a period of 24 hours. Then we divide it by 24 hours to get a like per hour infusion. Like that we start, and every 6 hours we repeat to follow up the results. So anytime the serum sodium is going above our expected range, we stop the infusion. So basically above as per this guidelines, above 12 can actually have a higher risk of Pontine myelinolysis.
That's an old term. So cerebral pontine myelinosis is an old term which is a misnomer because there is no myelinosis occurring there. So now the new term is osmotic demyelination syndrome. Basically what happens is there will be shift of fluid from the cells to the extracellular component, causing intracellular depletion of fluid. So because of this, patient ends up with neurological symptoms like seizures, coma, or any paraparesis, quadriparesis. So while correction of the patient is throwing seizures, it's not only because of hyponatremia, it could even be because of rapid correction. So which is why it is of utmost importance that we correct in a regulated fashion.
So this patient, because of the symptomatic hyponatremia, we give as an emergency as a bolus we give, and later actually when we check the lab reports, actually we found to have the patient is having low serum osmolality with elevated urine osmolality and urine sodium also, so which could be attributed to SIDH also, because considering the patient's drug history and all that. So later our plan was actually readjusted to like reduce the fluid intake, and also so our actually treatment plan changed from giving supplementation to like reduction of like excess fluids. So basically the patient is in a diluted state in his a system. So our main aim is to restrict the fluids, and also we added tolvap to this patient so as to increase the sodium levels. So and she was admitted for further observation.
As Sabat initially told here, you cannot just rely upon hyponatremia alone, no, for the cause of seizure. Was any imaging done?
So basically, any patient with acute or new onset seizure, we have to evaluate. And since the patient after the initial stimulation was stable enough for an MRI, we shift for an MRI. MRI with contrast was done. It was not showing any space occupant lesions or any other features which could actually exacerbate a seizure. So as per guidelines, the gold standard or the preferred imaging is this thing MRI. If we have the time frame or the this thing to do that, but in an emergency patient with any history of like an acute headache like before the seizure or like a probability of a space occupant lesion or like any probability of bleed, we have to go with an initial CT in ED itself. But if the patient we have time and after initial stabilization he is stable, then we can go for an MRI for a proper complete evaluation, especially in patients who have an oncology background. And also when a patient coming to ED, we have to also rule out other conditions like hypoglycemia and also other electrolyte disturbances like
Toxicology.
Yeah, what are the other electrolytes which can cause seizures?
this thing
Except for potassium, everything causes.
So
like
sodium, what all? Hypo.
Both can cause.
both can
Okay.
cause
Calcium,
Both can cause.
Both.
Except for potassium, all
Magnesium?
the electrolytes can cause.
magnesium hypo won't cause.
hypo can cause.
Hypo can cause. Hyper
usually
won't.
we don't see.
We don't see. Okay.
Okay, fine.
Then toxicology has to be ruled out if at all patient has taken any drug overdose, then poisoning, then
Not only overdose, withdrawal also.
withdrawal, yeah. Then infections, meningitis,
Meningitis,
encephalitis.
So this kind of patients we had to also think about after MRI go for an LP also to rule out any this CSF this infections and all that. And mainly EEG. EEG should be like taken like a long time, like about 8-hour EEG should be recorded to get an idea of what is going on. Because as we had discussed, this patient could also be in like a non-convulsive state also, because when she came she was drowsy. We could not know whether it is secondary to like a prolonged postictal phase or maybe secondary to the lorazepam which was given from another hospital, or maybe she is in a third time non-convulsive status also. So seizures basically can be like when we're presenting to it, it can be either a generalized tonic-clonic seizure, or it could be like a partial seizure with sensorium, intact sensorium, or maybe a partial without a sensorium.
Non-convulsive.
And then if it was a young child, they can even present with multiple absent seizures, like staring look can be there. And if the patient is presenting with low sensorium, maybe one DD could be a non-convulsive status also. There are multiple different types of seizures coming to ED. So our priority in any way should be like from our ABC only, we stabilize to from airway, breathing and circulation. But for the acute event, we usually give a benzodiazepine. Preferably a short-acting benzodiazepine like midas or something can be given. But the as per the textbook states, preferably is lorazepam because it has got a prolonged action. At least 6 to 8 hours action should be there. And if the patient is again throwing up seizures, we have to go for one more drug, like which is a prophylactic agent. Newer guidelines preferred agent is levetiracetam, which we can give 1 to 1.5 gram as per for an adult dose. And if the patient is again not improving, we can go for one more second line drug, like barbiturates or fosfonatone, anything can be given. Again, continuously throwing up, we have to go for like think about intubation and all
More
that.
than 40 minutes is the protocol, sir. So first Loraz, then phenytoin or phenobarbital. Then by this time you'll have like 20 minutes would have passed. Then for second line, 40 minutes would have passed. Despite this, then it is status. So with preferably propofol we can use to, because it has got anti-seizure.
That's post-intubation.
Post-intubation.
So
Even midazolam infusion post-intubation.
okay. So coming to this patient, basically we after evaluation, basically with the neuroimaging and all of the basic evaluations, we came to a conclusion that it's most probably secondary to that cisplatin-induced hyponatremia causing a acute seizure. So after the boluses and our correction and all that, she symptomatically improved. Sensorium regained after about 6 to 8 hours post-admission. But at that much delay, we were not sure what happened. But anyway, after that, she was completely conscious oriented and all that. After that, she didn't have any further episode. She was admitted for about 2-3 days and then got discharged in a hemodynamically stable state.
Okay.
So yes.
Okay.
Okay,
Fine.
thank you.
Thank you.